Oh,
Ah, c'est bien. On a Souad.
je suis contente de
C'est
voir.
formidable.
Oui, ça va, ça va. Je suis contente.
Alhamdulillah.
Voilà, je suis contente d'avoir pu être avec vous aujourd'hui.
Ouais,
Ah, c'est un vrai bonheur. Ah, c'est bien.
Merci.
Ravi de te voir.
Bah
Même
oui,
si
moi,
je suis pas
je ne croyais pas
parce
trop,
que-
et puis bon, bah, finalement, ça va. Ça va, j'ai pu être avec vous. Voilà. Je suis vraiment très, très contente que vous soyez là. Et puis, merci, merci Fadi d'avoir accepté la deuxième invitation. Voilà, et apparemment, alhamdoulilah, il n'y a pas de gag. Il a fallu avoir mon gag à moi, mais c'est bon, ça aurait pu se passer sans moi, mais c'est bien que je sois là avec vous. Voilà.
Un bonheur.
Merci.
C'est pas grave, ne t'inquiète pas. On fait le congrès national alors que je suis le présidente honoraire et j'y étais pas non plus. Hein, donc
ouais, je sais.
Les choses fonctionnent sans qu'on soit là. Hein,
ouais, tant mieux, heureusement, ça veut dire
heureusement qu'il y a les jeunes.
Ça va là, on a des bons collaborateurs, c'est bon. C'est
Voilà.
pas une question de jeunes, c'est, tu sais, des fois ils sont
relève.
jeunes, ils sont pas bons.
Nos collaborateurs, je crois que ça, vous pouvez nous le reconnaître.
Voilà.
Oui,
c'est les collaborateurs qui sont bons, exactement. Voilà. Bon, je crois qu'on va commencer hein, parce qu'on a un petit peu de retard là. Et puis bienvenue à tout le monde. On va commencer bien sûr à parler en anglais parce qu'on a j'imagine qu'il va y avoir beaucoup d'anglophones parmi nos participants. So welcome to everybody. It's a great pleasure for the Algerian Society to organize this 12th webinar about vascular surgery and with an outstanding speaker as Professor Fadi Sharber, who accepted this invitation. And also thank you to the panelists with Professor Abdel Halim Morsli, who is well known here in Algeria. He is the head of Department of Neurosurgery in Hospital Lamine de Berin here in Algiers, and one of our referent in vascular surgery. Also our guest from Morocco, Professor Ben Zagmout, from the team of Professor Chewi in Fez, and who is dealing a lot with skull base and endoscopy, and also one of the young neurosurgeons in Morocco who is dealing with vascular surgery, and also our assistant secretary in the Society of Algerian Society, Professor Houeri Lucif, who is also dealing a lot with vascular, particularly with the surgery of bypass. In Algeria, I think he's the referent now. He is working in private in the clinic Al-Azhar. So thank you to everybody. And I will let Professor Houeri to introduce our guest. Thank you to everybody. The parole est à toi, Houeri, s'il te plaît.
Okay, thank you, Professor Barti. I have a lot of things to say about Professor Fadi Charbel. He is very known in the neurosurgical world, especially in neurovascular specialty. He's doing both. I think that I'm not telling a mistake. Both surgery and endovascular. And he is the head of the Department of Chicago in Illinois. So he worked a lot I think that he will show us in his presentation how is his department and where is the engineering part and the technical part of all his inventions about probes and his NOVA system, and really as a neurosurgeon and a vascular neurosurgeon, we thank you a lot because you advanced this field of neurosurgery. So I know too that you have more than 215 publications, papers. So this is a huge work, and I think that I said a lot of things, and I will let you start your presentation.
Thank you so much, and good evening to all of you, my dear friends. We were speaking in French a little bit ago, and of course now the lecture will be in English. But thank you so much for the very kind introduction. I think that this is the best we can do. Professor Bakhti had so kindly invited me to come and join you for the meeting of the Algerian Society. And I was so much looking forward to it, to visit Algeria, your beautiful country with all the history. But let's hope we can do it again in the future in vivo, and that we're all healthy and we take good care of of ourselves. So I'm really very pleased that we're still doing this. And I will just say again that I will share something to show you before I start. Can you see this?
Yes.
Yeah, so this is what happened the last time. I wanted to do this talk, which is about really problems in bypass as much as thinking about bypass. And I worked so hard at it. And as you can see, 2:28 in the morning, the talk was finished and I went to sleep, and I get up in the morning and I check it again at 7:45 and you see error, error, error. And I called Professor Bakhti and I apologized profusely that I had to cancel on that day because it was going to be impossible for me to do the talk in the short period of time. So you know what I did this time? So this time I made 3 versions of this talk, not 1, not 2. I made 3 versions just to be sure that it will be ready. And I'm very happy that actually it is ready. So I will start by really thanking you and saying that I'm very appreciative to all of you, Professor Morsley, Professor Benzagmoud, of course, Houari, Professor Lucif, to be with you virtually. So the talk is about how is it that we can take a surgery like this, and after so many years, myself have doing it so many years, still have problems every now and then. And I thought about it, and I thought it'd be very apropos that we talk about a tale of 1,001 mistakes, because of course the inspiration is 1,000 nights and one night. And many of us, all of us, I think, are familiar with this. So for bypass, it's a story of 1,001 mistake. Be reassured, I will not talk about all 1,001 mistake. It's probably more than that. But I will give a try, generally speaking, to give an idea of some of those mistakes and what have we learned. And it's a little bit puzzling because when I was earlier in my career, I came across this work by John Hunter, who's a very well-known physician scientist. He was the mentor for Jenner, who invented the vaccine, truly a polymath. And he made it sound very simple. He said, blood goes where it is needed. So, I mean, so if blood goes where it's needed, how come experienced people, Dr. Lucif and I were talking a little bit ago about a puzzling case. How could it be that after so many years and doing it so much and studying so hard that we can still have problems? So I will go over these concepts that many of you have heard before, but I will put a little different twist on them today that will cover about what can we learn to avoid errors in bypass surgery. And for those of you that haven't seen this talk, I wanted to show you a little bit where we are right now. This is the Neuropsychiatric Institute. I'm sitting in my office here on the 4th floor of the North Tower of this building. This building is almost 80 years old now, and it was put together by Eric Oldberg. Eric Oldberg was the last resident of Harvey Cushing. So you see Oldberg and Cushing here. Oldberg came in 31, and about 10 years later in 41, he finished this building that looks like the brain. This is the original building that looks like the brain. And of course, this idea was then taken by Majid Sami, who came here and visited, and Amir spent time with us. He's a wonderful young man following in the footsteps of his father. And so it's a building with 2 towers and a corpus callosum designed to look like the brain. Of course, the building of the INI looks much nicer, more modern. But this building was completed in 2001, and the surgery, the first surgery was done 2 days after Pearl Harbor. So those were difficult times, and Sugar succeeded Oldberg, Oscar Sugar, and then Robert Kroll, and then my mentor, James Ausman, and then I succeeded Ausman. So that's the history of this building that's about 80 years old. What is new in this building is just this September, we finished the entire floor of this building, footprint, is now a fantastic laboratory. It's called the Surgical Innovation and Training Laboratory. And it's a very futuristic place that looks at using operative spaces and draws on the pedigree of the people that came before us, all the way from Cushing to Halsted. And here you see on the neurosurgery side, you see Ausman, you see Kroll, you see Bailey and Busey, and you see Gerard de Brun, and on the surgery side. So we all come together in a beautiful space. There's these microsurgery area. We have operating rooms, full operating rooms. We have real plants downstairs to give it an alive feeling. And this is our building here. This is the medical school that goes across this way. Professor El Abadi is very familiar with this. We had the honor of having her be our visiting professor here a couple of years ago. And the campus of the university is quite large, and it has a lot of work with engineering, like Professor Lusif mentioned. So I've worked with engineers for many years. We developed the technologies that you know about that helped us understand better bypass from a quantitative perspective. So let's start with the first question. Why do we do a bypass? And this is really a very, very important slide, because if we think carefully about this, then everything else will flow from this idea. Bypass is performed for one of 2 reasons. We're either trying to augment flow, which is ischemia, the bypass for ischemia, or we're trying to replace flow, such as when we trap an aneurysm and we have to replace the flow that is reduced because of the surgery. So only 2 reasons for a bypass. And the quantitative flow measurements that you heard mentioned are critical in being able to construct the bypass in a precise and algorithmic way, and to assess whether what we plan to do actually happened. So we can measure flow quantitatively at surgery with this flow probe that you see here. It's not Doppler, it's a technology called transit time ultrasound. So it doesn't give velocity, it gives the actual flow, and it's therefore quantitative. And with the NOVA technology, which uses MRI, which we can use before and after surgery, that give us measurement of flow in the blood vessels. So 2 types of bypass. And for flow augmentation, our algorithm now to evaluate the patients, once we have angiographic evidence of blockage and symptoms, is all MRI based. So we use the NOVA, and we use NOVA with and without a stimulus such as Diamox to evaluate flow in the vessels. And then we use the MRI sequences of BOLD to look at the global reserve after a CO2 challenge. And here you see the plane is blue on the right side. So that means there's no good reserve. And here is the functional MRI, which is the regional reserve. And you can see also on the right side, there's less activation compared to the left side. We also perform cognitive testing on our patients. We discuss them in conference weekly. So if everything fits together, then that's a good patient for flow augmentation with a bypass. So I'd like to emphasize this often, that in vivo, the driver of flow, which is reflected here by the Poiseuille equation, is not the diameter. Everybody thinks of the radius because the radius is the power of 4, la puissance de 4. So it is not the radius though, because in vivo, you cannot change the radius of a vessel. That's not really the issue. In vivo, flow goes from point A to point B because there's a demand, there's a pressure gradient, and that's what really drives the flow. And the next notion is that of cut flow. What is the cut flow? Cut flow is used when you use a vessel such as the STA, which is the most common vessel we use, and you cut it. And once you cut it, it's flowing without resistance. And because it's flowing without resistance, now you can tell what is the maximum capacity that this vessel can give. So a lot of people talk about the STA and say it's low flow. That is not true. That is not true at all. An STA can be low flow, it can be high flow. Really, those terminologies, low flow, high flow, are meaningless. What matters is the amount of flow. So sometimes 20 cc's of flow is what you need. High flow, low flow, it's irrelevant. But an STA can give flow that ranges from very little, such as 8 cc. I've had STAs that have given 200, 250 cc's. So you can have this problem of hyperemia that we were just discussing a little bit ago with Professor Lucif, even with an STA, if it's a good STA and it's a good bypass. So why do we measure cut flow? I'll show you an example. Here's a patient with moya moya, very nice STA. I measure the cut flow and it's only 9 cc's, 9. This is very little. I would expect more from this artery. So from measuring this cut flow and finding that it was low, it alerted me immediately before time passed that there was a problem. And what was the problem? There's a vein that was coagulating, crossing the STA, that was constricting it. And once this vein was cut, the flow is 10 times more. Now, if I did not check this cut flow, I would not have discovered this at the beginning of the surgery. You go ahead and you perform a bypass, you do all this work, and the bypass will occlude. So very important to measure the cut flow before doing the anastomosis. And once you measure the cut flow, and then you do the bypass, and if you compare the bypass flow to the cut flow, that's called the cut flow index. And it's simply what is the percentage of the cut flow that now the bypass is giving. So if the cut flow was 100 and the bypass flow is 100, that means it's 100% bypass, and that tells us that everything went very well. But if the index is less than 50%, in other words, after you finish the bypass, this bypass is less than 50% of the cut flow, you have to look very hard for the reason why. And we'll go over the details. But it is important, especially in flow augmentation, because the cut flow less than 50% is a strong predictor of a problem with the bypass. So what kind of problems are we talking about? What can cause the bypass to fail, to get us to the 1001 nightmares, not nightmare? Well, mainly two categories. The first one is poor indication. Poor indication simply means that the bypass does not have demand. Now, I will show you this case that I will show often because it's as good as it can get of a patient where we did a bypass to the superior cerebellar artery because the vertebrals were occluded. But notice how big the posterior communicating artery is. This patient already had a bypass that his body had given him. But we did not have flow measurements at the time, and we did a bypass. And I will draw your attention to the tracings here, which are flow measurements being measured throughout the entire surgery. In red is the STA. And you can see that the STA measured here is then clamped. And then once we cut it, you can see the flow goes from 2-3 cc's per minute to almost 70-65 cc's per minute. This is the cut flow. And you can see how the driver of flow is not the diameter. Obviously, this STA diameter never changed, but the resistance changed, and the delta P, the pressure gradient, is what changed. So the cut flow is very, very important. But when we performed the bypass and concluded it, you can see that that STA flow is still very poor. So the index is less than 15% because this patient did not need the surgery. This was a flow augmentation bypass, but the patient did not need any flow augmentation because he had a very large posterior communicating artery. So that's a type 1 problem. Where do you see that type 1 problem commonly? In flow replacement bypass. And flow replacement bypass is a bypass that we do commonly for aneurysms or tumors sometimes, but we do it to correct a deficit, to replace, in other words, a deficit that we have created during our surgery. And we construct the bypass specifically to replace this deficit. How do we do that? Here's an example, a large cavernous aneurysm transitional, and we want to trap the carotid. So we place a clip on the carotid and we measure flow. One flow now goes down from 70 to 50. So there's a deficit. How much? 20 cc's. We check the cut flow and the STA can give 44 cc's. So immediately we know that this STA with 44 cc's can replace the flow. It is sufficient. And this is what I did, an STA to MCA bypass. Now, take a look what happened here. The M1 flow at baseline is 70. After clipping the carotid is 50. The cut flow is 44, so it can replace the deficit of 20. But once we put the bypass and check the flow in it, there's not much flow in this bypass. Only 4 cc's. Why? Because there was no demand yet. But when we clip the ICA, in other words, trap the aneurysm, create the demand, now, of course, there's a flow in this bypass. How much? As much as needed, 20 cc's or so. So that is the flow replacement bypass. Here's another example, very complex basilar PCA aneurysm, cannot be clipped directly. So that's the position at surgery. We're prepared for everything. Left side, optic nerve, carotid, posterior communicating artery, basilar is here. Here's the aneurysm, and the P2 is here, and the SCA and the third nerve. So we have to trap this aneurysm, and when we do that, we will lose the PCA. How much flow we need to replace? 16 cc's. How much the STA can give by measuring the cut flow? Almost 40, 39. So we do not need a radial artery, we don't need a vein graft. The STA is enough. So I perform the bypass, pretemporal approach, STA to P2, right at the level of the third nerve, and we measure the flow again in the bypass. Only 5 cc's. Why? Because I had not trapped the aneurysm. I had not given the demand yet. But once I do, once I trap the aneurysm and the PCA is occluded proximally, of course, now there's a demand and the flow increases in the bypass. Here's the angiogram. You see the STA flow into the PCA. And when we measure with NOVA, now the flow is 70 cc's in this bypass. So the demand is what drives it. This is even more dramatic of a case. I want to show you here that I'm doing a vein graft to this M3 or M2 branch. And this vein graft is a very large diameter. It's 8 millimeters. So is this high flow? You know, a lot of people still make that mistake. Vein graft, high flow. STA, low flow. Means nothing. This is an 8 millimeter diameter. That is a fact. The flow we're going to measure. So after doing this anastomosis, and we finish all that, and the anastomosis is done, we're going to measure flow. And we'll see what happens. Look how big this graft is. But how much flow? Only 24 cc's, only. Why? Well, because, again, there was no demand yet. I have not occluded the carotid, And once I occluded the carotid, the flow starts to increase. 54, I sacrifice it completely. It increases even more. And now it's trapped. And now it's 83. And then now we completely occlude the carotid, and the flow now becomes 160. You see the vein graft filling the entire hemisphere, 160. The same vessel, the flow went from 24 to 160. So high flow, low flow, meaningless. You cannot tell from looking at the vessel. If you measure flow, you will know the real problem. So that's what I wanted to say about poor indication, type 1 problem, no demand. The second type of problems are technical. And technical, it's either the donor or the anastomosis or the recipient. So let's start with the donor, the STA, type 2A. I already showed you an example. There's so many ways to have problems with the donor, and that's why it's so important in the surgery to be perfect from the minute you start to the last stitch, the very, very last stitch. Anything can compromise the surgery, especially the donor. So 2A
in this
problem.
video, we demonstrate the occurrence of a common scenario where the donor vessel, the STA, can be injured. You can see in this case that there is a bleeding that was noted as the vessel is freed, and it's the superficial temporal vein which overlies the artery. The key point here is to not coagulate until the bleeding point is accurately identified. The coagulation should be performed while separating the bleeding vessel, the vein in this case, from the artery. Coagulation over the artery would otherwise risk injuring it and causing a narrowing and ultimately failure of the anastomosis from an early mistake occurring at the time of the dissection.
And I will remind you of the previous case. Once you coagulate it, don't forget to cut it, because that would otherwise cause a stricture.
This case illustrates the type 2A problem with the donor, the STA, which in this case is diseased and has a double lumen, which would make it very difficult to perform the anastomosis. This is commonly seen in atherosclerosis, but can also result from an injury, thermal injury, while harvesting the vessel.
So this double lumen is another very common problem. It can be very treacherous, because once you try to anastomose, you have two walls on one vessel, one wall on the other, and it's very easy to miss one wall and have a flap hanging in there, which will guarantee an occlusion of the bypass. Now, 2B. 2B is the anastomosis. And I would say that as far as technical issue, this is the most common problem. This is the most common problem, and this is the most common problem for people that don't have enough experience. And even if you have enough experience, it's the most common problem. So here's the general setup. You can injure the STA while harvesting it. So it's very important to keep it hydrated, to protect it. The drill can injure the STA. And the anastomosis, which we're talking about here, is the most common problem technically. You can have a mismatch in length between the donor and the recipient. That's why I put the toe first before the heel. You can catch the back wall. That's why it's important to inspect the anastomosis from the other side before doing it. Sometimes putting a stent is helpful. And of course, measuring flow is essential. Here's the anastomosis. The vein must be respected. So how do you avoid that? Well, you have to practice. This is a picture I took yesterday. This is at home. This is the microscope that I have at home. And believe me, if it goes a little bit before I have done a bypass, I will practice. I will practice. I'll sit there and I practice. So what do you practice on? I mean, it's at home. You don't have a patient. You don't have a rat. What do you need? What is the best training model for practicing? Well, there's a lot of training models. But I will tell you an anecdote. Many years ago, I had a fellow from Bulgaria. His name is George Kunin. I don't know where George is these days. And he was a neurosurgeon, very skilled. And I was talking to him one day and he said, you know, Dr. Charbel, I do brain surgery. I do bypass every day. And I said, what? He says, yeah, I'm doing bypass every day. And I got so worried because, you know, he was visiting us here. He doesn't have a license. And I thought he was telling me that he's operating on people and without a license. I said, George, how could that be? He says, oh, no, don't worry. I use chicken wing, the vessel of the arm of the chicken, which is a very good model. Actually, sometimes I use that at home. So you can use the chicken wing, you can use this model, which is a turkey vessel, do all sorts of things. You don't need a live animal. And frankly, I will tell you that you don't even need an animal. The best model, I believe, is this. This is a petal of a flower. So this is my microscope at home. And this is what you can do. You can fold it and anastomose it. The petal of a flower is very delicate, very thin. So it teaches you how to put the needle in the vessel without jerking your hand, how to pull the needle through the vessel without jerking your hand. Otherwise, the hole will tear. So you can do interrupted, you can do running, you can do whatever you want. And it's just the petal of a flower. You can find those probably all year round in Algeria and in Morocco. Lucky you. And then the third type is 2C. 2C is the recipient. 2C is the recipient. So you can have the same problem with the recipient. You can have a double lumen. If you have that and you don't correct it by tacking the intima, this bypass will instantly fail, instantly, because if there's a flap like this and you put a bypass, it will immediately circumferentially dissect and will occlude instantly. And this will be bad. But this problem is very common in moya moya, in flow augmentation bypass for moya moya. So you can detect it by measuring the cut flow index. And this is when we first started to understand this problem, type 2C, which is a recipient. So this is a great bypass with an index of 98%. This is another bypass. The angiogram looks good. It's very patent, but it's only 27%. This is carotid occlusion. This is MCA occlusion. So when you have an MCA occlusion, if you put a bypass on one side of the M2s, it does not go to the other side. So there's no outflow. It's a type 2C problem. So to correct for that, and this is the evolution of my bypass strategy for moya moya disease, to correct for that, historically, what was done is to do a double barrel bypass to revascularize as many territories as possible. Here's a moya patient with low flow. And when you do the first anastomosis, the index is only 58%. This is one bypass. And when we do the second bypass, it's another 44 cc's of flow. And now the index becomes 1. And you see here the STA trunk, 95 cc's, and the 2 anastomoses. So that's the classic double barrel bypass, which you can do for hemorrhagic moya moya as well. This is another moya moya. There's a double barrel bypass. And the double barrel bypass is a good idea, gives very good filling, like you can see here, very good filling, good flow, 74 in one branch, 42 in the other, another double barrel bypass. So this is the classic bypass that gives a lot of filling and corrects for the type 2C problem where the beds do not communicate very well. Very good. But what is the problem? The problem is that with moya moya, this is a progressive disease. We know it from Suzuki's early description, the different stages. We know it from the work that was done here, published by my colleague, Professor Henjani, who looked at following those bypasses over time. And we found that in a good number of patients, there's an involution of the bypass. So even though at one day we have a 96% patency, at 1 year, 74% patency. So if so, then you have to be parsimonious not to use all the vessels at the same time. So what can we do to correct for that? Here's a lady, young lady that has diabetes, terrible problem. She's almost going blind here. and the collateral is coming through her eyeball, through the ophthalmic, and the meningeal artery has a lot of flow, 90 cc's, so that's too much. So I wanted to make a high flow bypass using the STA, and here's the posterior branch, here's the anterior branch, and look how the pterion is notched, and this is to avoid injuring the middle meningeal. And what I did is a double bypass, end to side and side to side with the anterior branch, and with the posterior branch, I left it as an EDAS. And notice how the middle meningeal is preserved. And as a result, this is a high flow bypass, 167 cc's. Okay, again, STA does not mean low flow. And as a result, the flow in the collateral went down from 90 to 42 to help with her vision. Here's another Moya case. And what am I trying to show you here? Another problem. Look what happened here. I wanted to do the same surgery, but I don't know if you saw it. The brain is all red. You see how the brain is all red, the subarachnoid hemorrhage, because there was an injury with the drill, an injury with the drill. And that injury, the drill, caused subarachnoid hemorrhage and tore that posterior branch, tore both branches of the STA. So you can injure the graft with the drill. Every mistake possible I've made, and more than once. And hopefully I will not make it again, but that's not a certain thing. So you have to clean the subarachnoid blood to deal with that, measuring the flow here. But I wanted to do a double barrel bypass, but after I finished the first bypass, there was a very good amount of flow through this anterior branch. So I re-anastomosed the posterior branch and saved it as an EDAS. So I saved it as an EDAS. Here I'm re-anastomosing it. So it's still in continuity, the parietal branch. It's an EDAS, and the flow is good in it. It's backwards though. Look how interesting. And on the ICG, the frontal branch is antegrade, and the parietal branch, the flow goes from the scalp towards the brain, which is very good. And here's the angiogram. The anterior branch is a direct bypass, good filling, and the posterior branch is patent. Left it as an EDAS. So if this starts to involute, we still have this one as an EDAS. So the error here was injury, but repaired and left it as an EDAS. And here's the flow being measured in the anterior branch. Look at that, 122 cc's high flow. The posterior branch, the EDAS, is only 19 cc, which makes sense. So another variation, direct bypass, also direct bypass. This one is end to side. The parietal branch is side to side, but leaving it in continuity as an EDAS. Again, I worry that the bypass can involute. So I don't want to use everything at the same time. What if in the future we need to do something else? Okay, this is also good, but what can you do better? What you can do better is make a smaller incision and be less traumatic and use less vessels, maybe one vessel. So this is the first case where I did that in 2013. It was a very good anterior branch, 117 cc. So what I did is I did a side-to-side anastomosis first, and there was 67 cc's through that. Then I continued, and with the distal end, I did an end-to-side. And through that, there was an additional 40 cc's. So side-to-side, end-to-side, single vessel, double anastomosis, and now we have a cut flow index of 110 cc's in this bypass, and you see it here, side-to-side, end-to-side, 142 cc's on the nova using only one vessel. Now this is very nice because also this helps us avoid disrupting the collateral. So you can have one incision, a small incision, a straight incision, use one vessel, avoid injuring the middle meningeal, side to side, end to side, single vessel, double anastomosis. Presented that at the Moya Moya conference, done it many, many times. There are videos of this in operative neurosurgery, if you'd like to see them, to see the technique. This is a more recent case here, a very severe Moya Moya. Even another variation, you can use this parietal branch, keep it as an EDAS, and use a small branch as a direct bypass with the anterior branch. So you see, here's the EDAS, and the little branch, side branch, to do the direct anastomosis. And here's the ICG, that's the EDAS. You see not a lot of flow in it, back and forth. And here's the direct anastomosis that's going directly into the brain. And the NOVA shows it very nicely. That's the STA trunk. You see the flow is going forward. And then over here, that's the bypass going into the brain. See, it's going into the brain. And that little thing here is the EDAS, which has only 6 cc's of flow. The bypass to the brain is 97 cc's of flow. So you can become more artistic and more inventive. And today, this bypass, we call it 1V2A, one vessel to anastomosis, or SVDA, single vessel double anastomosis, or also you can call it the Minimax, because it's a minimal trauma and maximal benefit. And direct bypass, many compartments, index of 1, as few vessels as possible, minimum trauma, do not disrupt collaterals, and for ischemia, exceeding 100 cc's can cause hyperemia, and in severe cases, hemorrhage, which is a disaster. So to summarize, there is at least 1,001 ways to make mistakes with this operation. Hopefully you will learn from mine so you don't have to repeat them. Starting with the vessel, very careful with the donor, mark it so it doesn't twist, clean it before doing the anastomosis so it's no adventitia, so it's very pristine. Save the collaterals, the middle meningeal, they're already there, they're doing a bypass, don't disrupt them. So you see here, there's this stitch retracting a little bit, that bridge of the middle meningeal to do the anastomosis, and the clip is under it. Do not sacrifice it if you don't have to. Respect the vein. Look at this vessel here. It's deep, there's a vein next to it. It's difficult to put the clip, so you can put a little stitch on the adventitia of the vein and tie it to the dura, and this way you have more room. Do not coagulate the vein, do not use a retractor. And we do the surgery, we still do it. It's one of the most beautiful surgery you can do. It's technically demanding, it's aesthetically beautiful, and that's why I'm paraphrasing Voltaire, that probably here, if the surgery did not exist, we probably would have had to invent it. So how to avoid mistakes? The microsurgical skills are necessary. They're absolutely necessary. It is technique-based, but it's not sufficient. If the surgery is not constructed properly, by thinking carefully, what are we doing it for? Are we doing it for flow augmentation, or are we doing it for flow replacement? And by knowing exactly how much we want to replace, there's something that would be left to be desired, because at the end of the day, this surgery is a means to an end. That's why I have pictures to Machiavelli. It's a means to an end. The surgery is not the end. It's only a means to an end. So that's all I had to share with you today. I salute you for doing all this work, to keeping us together, and for staying with us, with me certainly at this very late hour. And again, I was there with you. And if we have time, we can have some questions.
So thank you, Professor Schaber, for this very nice presentation. I'd like to ask a question about...
I think Mr. Bhakti is on mute.
Okay.
Swad, you are on
It
mute.
is just to tell you, thank you very much. Outstanding talk. And as I always told you, I'm not a vascular surgeon, but when you are talking, I will be a fan of vascular surgery. Thank you so much. So
and we are all your fans, Swad, Professor.
Merci, merci Fadi. Houari, ben maintenant you can begin please to organize the.
Yeah,
I
okay.
think there is a lot of questions from the panelists, and maybe after from the chat, Nabila will search on the questions. So, vas-y, Houari.
So the question that I have is about Moya Moya. You know that the vessels of Moya Moya are diseased vessels. They are too thin. So how do you choose the right one to bypass it? And do you use a special technique to avoid tearing? You know, when you put your needle in it, and
Yep.
what is the trick?
What are the tricks? So, of course, Professor Lucy Houari, you are speaking from experience, Houari. Please remember what you just heard, that a bypass for Moya Moya technically is much more difficult than a bypass for aneurysm, much more difficult. As you heard, the vessels are very fragile. So for Moya Moya, you are between two things. One, if you pick the most superficial vessel, it's usually small and thin and not a very good recipient. And it can be so thin that it's almost impossible to maintain a good suture in it. So sometimes in Moya Moya, you have to go a little bit deeper, find one into a sulcus. And it's made more difficult because the arachnoid of Moya Moya is often thick. And of course, you don't want to use a retractor. So like that case that you saw me, I put a retractor on the vein and so forth. For Moya Moya, just remember, I think technique becomes paramount. How you put the needle, how you support the needle. Do not pull it in one move, multiple little movement, pull it a little bit at a time, a little bit at a time. That's where I think the practice on something very fragile like the petal of a flower helps for Moya Moya in particular. And the answer to your point, Houari, is practice. Moya Moya is much more difficult bypass. I would say the most difficult is Moya Moya.
So I find a personal solution for this tearing. I put a small patch. You know, every time that I put a needle, I patch it with some tissue. That I don't know. What do you think about it? I don't have 10 years experience like you, but do you think that it is a good idea for, you know, because when we think, we can say that in time, with the time, this mouth of this anastomosis will like shrink with this tissue around it.
Yeah, that's a very good idea. And it's a good salvage technique. Bin Shu, my friend from China, uses something similar. I think it's a very good salvage technique. But you're right. I think that there is a chance, there's a risk of this causing scarring and reducing the stoma. So I will only use it if necessary, but not primarily.
So if you have bilateral, you know, carotid stenosis, bilateral Moya, how do you choose the side that you will do first, or you will do the two sides, or?
Yeah, great question. I do not do both sides. I do not do both sides for a number of reasons. The first one is that sometimes you do one side and it can help the other side. Number two, I think patients can have some symptoms after a while, and I like because the hemodynamics redistribute, so I don't like to do them at the same time. I like to wait a minimum of 6 weeks between one side and the other and let the patient heal. How to choose? A number of factors. The first one, of course, is symptoms. If a side is symptomatic, then that side usually takes precedence. Second, if they're equally symptomatic, right and left side, the dominant hemisphere takes precedence. So if we want to protect one side first, protecting the dominant hemisphere first would make a good sense. The third one is according to the blood flow. If everything is equal, the same size, etc., then we look at the hemodynamic compromise. If one side is more compromised than the other, that would be another factor. So those three things: where are the symptoms, which tissue is more at risk, and which side is more compromised. So just before going on this conference, I had two patients that need a bypass. I spoke with them, one of which had strokes on both sides already. Unfortunately, her left side was already more damaged. It's a sad story, you know, believe it or not, this poor young lady was told that she had multiple sclerosis. So for 7 years, 8 years, she was seen in neurology, and they were treating her for multiple sclerosis. And she kept having stroke after stroke, and she had actually moya moya. Very sad story. So her left side is really damaged, and there's not much to salvage, but her right side is still good. So I spoke with her, spoke with her mother just today, and I explained to them that even though the left side, of course, is dominant, we're going to the right side because there's more to save there than on the left side. So it's a key question. There's a lot of judgment to go into that, and I'm glad you asked it.
So I think that I will ask you the last question, then I will let my colleagues ask you the others. Do you have in your huge experience to put a bypass for a posterior circulation?
Oh, yeah.
I mean in moya moya?
In moya moya, no.
Mm-hmm.
I've never operated on a moya moya of the posterior circulation.
Okay, I will let my other colleagues ask questions.
Professor Mosley.
Thank you, Mr. Chaber, for this interesting topic. The bypass is very important in the treatment of the all neurovascular lesion. So I asked you in French for explain my idea. La problématique de la prise en charge des anévrismes complexes surtout au niveau de la carotide clinoïdienne, supraclinoïdienne, carotide ophtalmique, pose un problème de chirurgie classique, surtout dans les cas où l'anévrisme est géant avec un collet qui est large. Et lorsque l'ossif était avec nous, donc ça nous a posé beaucoup de problèmes de prise en charge. On ne pouvait pas faire de clipping. On posait l'indication d'un bypass avec exclusion de la carotide. Laisser la carotide et essayer de faire donc un bas débit donc par la STA et rechercher la thrombose dans d'autres cas de l'anévrisme. Donc, dans toute cette situation, est-ce que les indications sont posées, comme vous l'avez si bien dit, selon le receveur? C'est quoi comme type d'anévrisme? L'artère, comment elle est? Et surtout, la différence entre le high and the low flow dans ces situations, et le problème est posé. Donc, quelle est votre conception de la lutte? Je sais que c'est votre dada, c'est reconstruire une artère qui est anévrismale. La revasculariser, ça, c'est l'idéal, oui. Ce n'est pas tout le monde qui le fait. Vous n'êtes pas nombreux à faire tout ça, donc avoir une situation intermédiaire entre le clipping classique et la reconstruction d'une artère qui est malade, le bas débit peut-il régler le problème, soit par l'exclusion de l'artère porteuse, la carotide, ou entraîner la thrombose de l'anévrisme par une inversion du flux. Donc tout ça, c'est des conceptions pour les jeunes, pour comprendre quelle est, dans une situation intermédiaire, la meilleure prise en charge, dans des conditions qui sont les nôtres. Ce n'est pas les conditions que vous avez qui sont extraordinaires et qu'on veut bien avoir. Quelle est votre idée sur ça et l'expliquer pour tout le monde, surtout pour les jeunes? Merci.
Okay, so for those that are listening in English, what Professor Mosley asked a question is the classic question of flow replacement bypass for proximal aneurysms, complex carotid aneurysms, like that case, that first case that I showed. So this is the classic situation of flow replacement. And the question is, what is better? Is it better to try and reconstruct the vessel, or is it better to do a bypass? And once you do the bypass, should you sacrifice the vessel, or should you just let the bypass be and see if the bypass itself will cause the aneurysm to thrombose spontaneously? This is basically a whole book of neurosurgery, and I will try to summarize it. Is it okay if I answer it in English, or do you want me to answer it in French? Up to you.
In English,
English.
please, Freddy, in English.
So the answer to this is, of course, in many parts of the world, the flow diverters, there's no access to flow diverters. In parts of the world where flow diverters exist, now this has taken over many of those aneurysms. So, but many places you don't have flow diverters, or flow diverters are very expensive and so forth. So this is the classic case of flow replacement bypass. And if this aneurysm is to be treated, the most appropriate thing to do, if you cannot clip it, of course, you always see if you can clip it. But if there's a chance that this aneurysm may not be clippable, before attempting to clip the aneurysm, a large paraclinoid aneurysm, before that, to do the bypass first. I have seen many very experienced neurosurgeons, and I remember being in live surgery together, and they take this aneurysm, and I said, you know, don't you want to do a bypass first? They say, no, I'm very experienced. The problem is, once you're into trouble, there's very little time for a bypass. An hour can pass before you can put the bypass. So how you do it? It's really very algorithmic. So Abdul Halim, this is a algorithmic, by definition, approach to flow replacement. How do you do it? Typically, if it's a carotid aneurysm, what you're thinking you want to do is proximally occlude the carotid, or maybe trap it proximally and distal. So what you do, you expose everything, you split the fissure, you have the MCA, you have the ACA, and you have the STA already isolated. What I do is I measure the flow in the MCA, then I put a temporary clip on the carotid, and I measure the flow again, and I see how much has dropped. Is it 10 cc's? Is it 20 cc's? Is it 100 cc's? Whatever it is, I note that number. And then I take the STA that I already have isolated, I cut it, and I check the flow in it again. If the STA can replace this deficit, then I use the STA. If the STA cannot replace this deficit, there's other strategies that one can use, such as doing interposition graft, using a wider diameter vessel, and so forth. But the key here is that if you put a bypass, like an STA, and you do not create a demand right away, this bypass will thrombose, like I showed you example after example, because there's just not enough demand in it. There's no demand. The demand is only created once the carotid is occluded. So the best thing to do is to check the deficit, calculate it properly, perform a bypass, try to clip it, and if you cannot clip it, then occlude it right away with confirmation that the bypass is good. And this way prevents one of the complications that happen if you don't occlude right away, is you can have opposing flow and you can have embolic event. You can have thromboembolic event. And we've seen those. So even though in patients, you remember from the literature, that had passed balloon occlusion test, even though they passed the balloon occlusion test, no problem, you occlude the carotid, they can still have strokes from embolic problems. So it's important to trap the carotid under the protection of a perfect bypass, and that's the best way to do it.
Thank you.
So I think that there is a point here for this kind of aneurysm. We have to, like you said, trap it in the neck and in the brain. Open the brain and trap it between two clips to avoid this thrombolic.
Especially if it extends above the ophthalmic.
Okay.
Because the ophthalmic was still retrograde. Now fill it, and you'll have thrombus forming, and you can.
Is it okay for you, Halim?
Excellent.
May I have
Thank you.
a question?
Dr. Najia, please,
Oh.
can we talk before with Professor Ben Zagmout, and after it's you? You permit?
Yes, of course.
Thank you, my dear. Professor Ben Zagmout.
First.
He's here.
Are you with us?
Yeah, I said Professor Abadi first, if you allow me.
Okay.
No,
Okay.
no.
Thank you.
Thank you,
He's a
Smahan.
gentleman.
Yes, of course, of course. My question is about when you are faced the giant aneurysm, and especially in the middle artery, and you need to. I know it's not the topic today, but this question is it's always I'm always thinking about. And when you have, we know that giant aneurysm is rarely bleeding, but in the case of we have a bleeding with giant aneurysm of the middle artery, and you need to protect your artery by doing a bypass before. And we know in the I mean in the beginning of after the bleeding, there is many swelling, there is many edema, and you think it's very easy to perform the bypass, and then of course to go to clipping and reconstructing the middle artery with clipping the aneurysm. This is my question. I mean, I think you understand my meaning.
I understand perfectly, Najia. Thank you. A giant aneurysm is a difficult aneurysm.
Yeah.
More difficult than a non-giant. A ruptured aneurysm is more difficult than a non-ruptured aneurysm.
Yeah.
A giant ruptured aneurysm is basically as difficult as it can get. This is not a gift that the gods will give you that day.
Is the biggest difficult cases I think in the world.
No doubt very difficult.
How you can dealing with, because I have a case like this, and I was really.
Now this is where so when we have ruptured aneurysms that need a bypass, where you have to sacrifice, say, the carotid or the MCA, if the aneurysm is ruptured, this is where we break the rule, and we always use a large conduit bypass, meaning a vein graft. And you are wondering, why is he saying that? He just told us floor replacement. No. This is the exception. When there is subarachnoid hemorrhage and you must sacrifice a large vessel like the MCA or the carotid, and you have to do a bypass, therefore, to correct for the deficit, okay, you have to do it. It's more difficult, but we can do it. We can do it. It's not a problem. We do it. But we always use a vein graft. Why? Because what happens when there is vasospasm, which can happen?
Yeah.
Now there's vasospasm. The carotid is occluded. How can we do an angioplasty? How can we give verapamil? It's not possible anymore. So this is why, in those cases, we have published that in bypass for subarachnoid hemorrhage, we always use a large conduit. Remember, I'm not saying high flow. I'm saying large conduit, because through that vein, we can then do an angioplasty or infuse verapamil through the STA, it's not possible, because if you put a catheter through the STA, it will spasm very quickly and will occlude, and that'll be the end of it. So it's a great question. It's a difficult surgery, but if a bypass is needed, bypass is needed. Now, the other possibility is to accept an imperfect result. If it's not possible to do a bypass, if the patient is very sick, if there's other conditions, then in that case, maybe the thing to do is to partially clip the aneurysm, partially, and just to save the patient, secure the aneurysm portion that has ruptured, not compromise all the vessels. So the aneurysm is not fully cured. It doesn't look perfect on the angiogram, but at least it's secure. And then let the patient recover, and then either come back later when things have settled down, or consider an endovascular option, depending, of course, on the anatomy. And this is very reasonable. We have to be honest. Sometimes this is the best for the patient. Let's say it's the middle of the night. Let's say you're at a hospital that is not equipped for a bypass. You do not have the nursing team, etc. You cannot do it. Certainly has happened to me. So then that's the best thing you can do.
Yeah, thank you so much, because I have one case this weekend that I was very depressive because this surgery, because we have in per-operatively, I think it's on Saturday, we have not our usual team, and we have you have a really swelling, very swelling. I never did this edema in my life, and we was very the situation was very bad, and we succeed finally to close, because the problem is has very enormous swelling, edema, and we can do it anything. Just closing for us, it was very huge, and this is my question. Thank you so much, Fadi. It's
for someone with your experience, that's the perfect thing to do.
Yeah. Thank you.
Thank you. Professor Ben Zermoud?
First of all,
you can see Mohammed.
Thank you, merci.
I know you are less younger than me, but you know, in the sciences, no age now is very important.
Thank you. Thank you. First of all, I would like to thank you, Professor Bakhti, Nabila, Professor Louari, and all of the Algerian Society of Neurosurgery for their kind invitation. Then allow me to congratulate you, Professor Charbel, for your wonderful talk as usual. Let me say firstly that I've never done bypass before, but I hope I will do in the future if needed. And let me ask you a couple of questions. The first one is regarding how do you make the choice of the donor vessel? In other words, when you decide to choose a venous graft instead of arterial one. And the second question is regarding complication in the graft, except stenosis. Have you seen aneurysmal formation inside the graft after long term? The third question. What kind of bypass you advise for beginner? Do you advise to start with revascularization or replacement bypass? And the last question is, except microsurgical equipment, what are the other equipment needed or mandatory to do this kind of surgery? Thank you again. You should unmute yourself. Sorry.
Thank you. Great questions. And we all started one day. So you have not started, you're going to. The first question was about the choice of the donor. For any flow augmentation bypass, the donor is always the superficial temporal artery, and with some exception, the occipital artery. There is no room for anything else because the vessels are small, you do not need too much flow, etc., etc., etc. Very simple. For flow replacement bypass, the choice is determined by the demand. So what if you want to do the surgery in the best intellectually satisfying way, what you want to do is to follow the flow replacement algorithm that we published many times and I just spoke about. You determine how much flow you need and you use the simplest technique possible. Meaning, most of the time, the superficial temporal artery is very sufficient. Sometimes you have to use a short interposition graft, so you can put a little bit of vein graft between the origin of the STA and the MCA. And rarely you have to use a longer graft. So that's really how you choose a donor. It is dependent on the necessary replacement. When you start, which bypass you should start first? You know, there's 3 different types of bypass. There's the end to side to side, and end to end. The first bypass you should master is the end to side. So it's by degree of difficulty. So hard, easier, easiest. There's no easy bypass, but the hard, and when you do side to side, remember you are risking 2 vessels. So it's always better in the beginning and safer to do end to side, end to side, end to side until you're comfortable with that, and then move to the other kind of bypasses. As far as complications, stenosis, we've seen it all. Sadly, I've seen it all. Yes, you can have stenosis of the graft. You can have involution of the graft. Aneurysm, of course. In fact, I think maybe last year or so we published on a patient of mine that I did an aneurysm on one side. I did a bypass on one side, and he developed an aneurysm on the bypass. Now, he needs this bypass, but to treat the aneurysm, I have to occlude the bypass. So I decided first to do a bypass on the other side so that at least the other side is protected. And if you look it up, it's a fascinating case. I did the STA on the other side. That STA on the other side provided 250 cc's of flow, 250, 250. This is very high flow. And you know what happened as a result? This bypass here decreased and occluded, and the aneurysm disappeared. So yes, certainly it can happen. And I don't know what your last question was. Maybe that was your last question.
Equipment mandatory to begin this kind of surgery.
I'm sorry? The equipment?
Yeah, equipment
Yeah.
needed for this.
You need very good microsurgery equipment, and you should protect them. The operating room is a difficult place, and if your nurses are good, yes. If not, I keep my equipment with me in the operating room because they destroy them, even though we have good nurses. And if possible, I think the flow probe is really essential. Once you start measuring flow, if you can, I know it's not easy, it's not feasible. There's cost associated with that, and I completely understand that. Even in the United States, not everybody has it. But once you have the opportunity to measure flow, it really brings another dimension to help the surgeon at surgery.
So I
May
think
allow me, please, Fadi, to tell you something. You know, I think my friend Suad Bakhti know that we have jumelage between our university and the University of Illinois of Chicago 1 year ago, but unfortunately, because the COVID-19, we stopped all. Everything is stable. It's not stable, but stop it. Why do you think about to organize some workshop in in an area of Maghreb? I mean, Morocco, Algeria, maybe Tunisia. In Morocco, it's it's less expensive, and of course, to this workshop where we will be dedicated to bypass. I know we had before 1 and 2 years before with Yuko Kato 2 workshop in bypass and endovascular and vascular surgery. But in the bypass, I know it's very easy. I saw it. It's very easy, but technically, generally, technically speaking, but we need. I mean, we need to first to know how to do it, and then of course indication is of course it's learning, and we're learning of a lot of from you and from essentially from you and from others colleagues how the indication, but the technique is I know the technique is easy, and we need the help from our friends from USA, especially from like Fadi, to start with us this program as workshop, of course, after the COVID, and we're hoping this unpredictable crisis, sanitary crisis, go over, get better. And what do you think?
You know, Najla,
First, I think my friends Fadi need to should to answer for this question. He is he
I want him to answer after what I have to say, please, if you permit.
Yes.
Because you know, when we have the first problem with Fadi, you know, with his computer for the first webinar, we discussed with my friend Halim, and we have discussed, but just for really a local experience, and maybe it can be added at what we are saying. We discussed with Halim and said, okay, this time he can come from the webinar, but at condition the next time he will come here and we can organize a workshop. It was between just the department, you know, his department and mine, and we think about that. But nevertheless, rien n'empêche that the experience can be biggest, and maybe we can do that. Of course, it will be a great idea to have a workshop, and if Fadi accept to come for live surgeries and for a workshop like this, of course we can do that. We can make a reflection where we can do that, or maybe we can do that some one time in Morocco, one time in Algeria, one time in Tunisia. But we have to think about that since 2 months. If Halim remember that, he was the first to give me the idea.
I totally agree, and
now la balle, as we said in French, la balle est dans le camp de Fadi. If he accepts after all these problems of COVID, and we can imagine the solution, how we can have prices for young residents from Maghreb. We can do that with the
Arab also.
with the Maghrebin Association of Neurosurgery. We can imagine a lot of things like this. And just we have to have his accord, and we can make a reflection on that.
Yes.
What do you think, Fadi?
First, I totally agree with you. And their women decide, and I know him very well. I'm sure that he's like Kinin, because we are two women to decide. We need to have somebody, but I know that he is very, very busy. I visit him, and I know that he is the star of the dean of university. So this is why I propose that we will organize this workshop. Once in Morocco, once in Algeria, once why not in Pan-Arabic?
For example, or just we can begin
in Arabic countries. But it depends on her skills and his activities.
Yes, he has to choose a date, and of course, it will demand time to organize.
We are dreaming, of course. We are dreaming because we are not go after the.
First of all, we have to go through this pandemic situation, and I think that when we close to the end of this pandemic, we can have more visibility about the future, how we can organize timing, how we can organize the tripping and things like this. What do you think, Fadi?
Of course, my dear friends, I mean, this would be a great pleasure and an honor for me. But it would be a great pleasure. Those things are based on your leadership, and I am with great pleasure at your disposal. Very happy to do that. For many years, I organized that. I just stopped this last year, but since 2004, every year I did those live surgeries and live courses in Italy once or twice a year at the University of Padua. So for 16 years. So I think it's a very good idea to do this for the purpose of education, to have a course and show surgery, and then au fur et à mesure, I mean, progressively, everybody, you have discussions, you have talks, you have a dinner, you talk, you review the case, then you practice a little bit, and I think there's no doubt about it, and I completely agree with you that it's an excellent idea, and I would be very happy to.
So I think that we have to work on the project, to imagine it, to feasibility, to all these things, and of course wait a little bit the end of this pandemic situation, and maybe we can organize in the future regarding your agenda and things like this. Maybe this is the solution.
I agree 100%. We have to look at the future, and hopefully we will all get there together safely.
Just before finishing, I just want to ask Professor Bouyousef, are you still with us, please? Il était là. Il est là, regarde. Professor Bouyousef.
Oui, Joanne.
I want you to say something, please, today.
Something today about the conference?
About, yes, the conference, your feeling about what we are telling about the course?
The collaboration with our friend about the bypass to, bypass is one of the, you are of the pioneer, and you know that bypass in the 18 was it's very, it's technical feasible without any problem. And then there is
It's very trendy.
yeah, but 10 years or 20 years after, it was very it's not fashion technique, and now it's really fashion technique, but efficient technique, I would like to say. And of course all our young and seniors less than you don't know to of course perform this technique. And with our friend we have the chance and lucky to have Fadi, that he is really very kind and very disposable to start with us this project. I know we can do it anywhere. It doesn't matter when I'm saying in Rabat, because he know Rabat very well. He know the Iowa University very well. He know what he need. And I think what he needs for doing this surgery, we can do it in our department. But we can do it once in our department, next one in Algiers,
Najia,
yeah. Excuse me. Yes,
Professor
please.
Charbel knows already Rabat. I think that next time we have to come to Algiers first.
No problem.
I would like to thank him really, because the conference is very, very good. And I assist before when you give this same conference on the Moroccan society. It's a very, very interesting subject. Personally, I am a great the founder of vascular neurosurgery, doing by neurosurgeons, but only by endovascular surgeons.
I know.
And second, the idea to create this committee of workshop in Maghreban area. I think I support this idea, because I think that we need this kind of thing in our countries. And thank you once, my friend Charbel.
The pleasure is mine, Professor Bouyousef Khairuddin. I know your pioneering work, and I've listened to your conferences, and it would be a pleasure, certainly a pleasure, to be among friends and to do everything that we all want to do for the next generation, of course.
Well, thank you to everybody. Thank you very much, my friend Fadi. Finally, we have had our webinar.
Thanks to you and your persistence for inviting me. And I'm so glad to see everyone doing
really
well.
Outstanding. Thank you to all the panelists, to Professor Halim Morsli, to Professor...
Souad.
Oui, pardon. Oui.
S'il te plaît.
Oui.
Je voulais rendre un hommage. Il y a quelqu'un qui est parmi ceux qui ont assisté à notre webinaire, c'est M. Ashraf Ahmed, qui est un neurochirurgien d'origine afghane et qui est à Grenoble.
Ouais.
Et c'est avec lui que j'ai appris, il y a 20 ans de ça, donc la neurochirurgie vasculaire à Grenoble.
Oui.
Je crois qu'il est en train de m'écouter.
Oui, j'ai vu ce nom,
ouais, c'est M. Ashraf, pour lui dire toute ma gratitude. C'est quelqu'un d'extraordinaire. J'en ai parlé aux plus jeunes.
Oui,
L'Ossif, tu te souviens? C'est Ashraf, c'est Ahmed. Salut Ahmed.
Eh bien, écoute, nous le saluons et merci beaucoup à lui d'avoir assisté à ce webinaire. Et c'est un honneur pour la Société algérienne de neurochirurgie qu'il soit parmi nous. Voilà.
Merci. Merci, Fadi.
Finalement, je vois que je ne suis pas la seule à avoir clippé un anévrisme en dehors du Maroc la première fois. En tout cas, merci à Abdelhalim.
Voilà. Donc, thank you to everybody, and I hope we meet in presential next time. But these webinars all at least permit to us to see us in our houses, in our offices, and in this year it permit to us to see us. It's at least a good thing. Keep safe and see you next time. Thank you so much to be with us today. Thank you.
Thank you, everybody. Thank you.
Thank you.
Merci beaucoup.
Bye.
Bye.
Merci beaucoup. Merci Fatih. À bientôt.
Bye bye. Bye, Najia.
Très bon webinaire, nos amis algériens, et comme d'habitude, Fadi, il n'y a aucun mot pour exprimer ta disponibilité, ta gentillesse, pour les Maghrébins et de façon générale pour les Arabes. Merci. Merci.
À toi aussi. Merci, chère Najia. Bye bye.
Merci, au revoir.